I'm Dr. Mike DeVoe. I am currently the interim chair of the ETSU Department of Pediatrics. I direct the newborn intensive care services for the university, and I also direct the Northeast Tennessee Perinatal Center. Regionalization is a concept that was put forth by the Department of Health 25 to 30 years ago in an effort to organize and improve efficiency of delivering perinatal and prenatal care to the residents of Tennessee. The benefit of the system as it was set up was to try to utilize existing resources to try to improve efficiency and optimize the use of state resources to improve perinatal outcomes. If you really step back and kind of take an overhead view of the whole perinatal system, something else that our system has done that I don't think has been recognized enough is that we have really done a lot of pilot projects, for example, that have assisted the Tennessee Department of Health. We are using our expertise as an established perinatal center to help the whole Southeast United States region, again through CDC and HRSA. So these are all types of things that the state did not have the resources to do on their own. They called on existing expertise to be able to help the state put together a good package, et cetera. So we're working at a lot of different levels, and again, it's far beyond just patient care.
The outreach teaching from the Perinatal Center has been significant, not just for patient education, i.e. nutrition, exercise, trying to keep a young pregnant woman comfortable but not overweight and not undernourished, and has been good. But also their interrelationship in educating and upgrading education of the nurses and the medical staff here. One child was born essentially dead with an APGAR score of 0, and yet with the Lord's intervention has been well restored to a wonderful, healthy situation. I sometimes am so grateful to the Lord and to the Regional Center for their backing and help to get this young lady back to a full functioning life. She's a high school junior now, and I'm thankful for her life and for her health and for her vitality, for her intellect. But somewhat irreverently I said, but Lord, she's so beautiful, you're just showing off now. Because you didn't have to do all of this, but I'm sure it was His pleasure.
I started in this position almost 27 years ago. At that time, our intensive care nursery had a 10-bed unit. Right now, as of last week and last month, we were pushing around 40 babies in the intensive care nursery. We depend on the regionalization system and the funding because without that, these resources would not be available. We are the kind of the cog that turns the wheel in terms of making sure that these resources are available and that they continue to be available for these families. With the agencies in the community, staying in touch with those agencies. For example, with Child Protective Services, staying current on who those workers are and the relationships there so that a baby will be safe when he or she goes home. Staying in touch with early intervention services and that networking so that those resources stay in place.
As a pediatrician, I generally deal with the product of the Regional Perinatal Care Center, if you will, the baby. The first time I meet a child is usually a day or two after discharge from the neonatal intensive care unit. At this point, there are a lot of moving parts, a lot of follow-ups to be arranged, whether it be with subspecialists, retinopathy checks, early intervention services. All these things are arranged by the discharge planners at the neonatal intensive care unit, which provides for a seamless transition of care. Generally, when the parents come to me, they already know when their discharge appointments are, who they're with, and what they're for. They know what to expect, where to expect to get the services. Again, in this region, often we have to send people to other places, even to Nashville for the retinopathy checks. This is all set up, and it's a wonderful service that the regional center provides. One of the greatest challenges to delivering healthcare in this region is timely access to quality care. The transport teams, the availability of the neonatologists and the NICU staff may fill this gap for us. As a pediatrician, the biggest thing is transitions of care. Of course, as you go through this process, you're turned over from obstetrician to neonatologist and then eventually to pediatrician. There are many pitfalls to any handover of care in healthcare. We all know this now. So the discharge planners and the neonatal follow-up clinic really bridge this gap to make sure that none of the pieces are missed, nothing's left behind, all the children receive the services that are available to them and the services they need to thrive.
I think some of the things that have made it so successful and what's required for continuing success of the program is, number one, a stable source of funding. And I think one of the messages to get across to everyone who deals with funding in Nashville, and I know times are tough and healthcare is changing left and right, is that none of the perinatal center funding dollars go directly towards patient care. Other things that are required to make it and keep it successful would be we have to be able to provide a consistent service across the state. We really can't have any gaps in service provision. And again, service, I'm not talking about direct patient care. I'm talking more about our educational role in assisting the state. I mean, we have to be there as a resource that's ready to go anytime the state has a new project that they think may benefit perinatal outcomes.